Heart failure for internal medicine students. Topics covered in this discussion are 1. Universal definition and classification of heart failure. 2. Heart failure with improved ejection fraction. 3. Role of cardiopulmonary exercise testing in heart failure. 4. Left ventricular remodeling. 5. Left ventricular reverse remodeling. Over the years, there have been several definitions for heart failure, leading to non-uniformity in the literature on heart failure. To bring uniformity, especially for heart failure clinical trials and registries, a universal definition and classification has been published by a joint writing committee of Heart Failure Society of America, Heart Failure Association of the European Society of Cardiology, and Japanese Heart Failure Society. The definition has been endorsed by major heart failure societies worldwide. The Joint Writing Committee defines heart failure as heart failure is a clinical syndrome with symptoms and or signs caused by a structural and or functional cardiac abnormality and corroborated by elevated natriuretic peptide levels and or objective evidence of pulmonary or systemic congestion. Just as the universal definition of myocardial infarction includes cardiac troponins, this universal definition of heart failure includes natriuretic peptides. The staging of heart failure has also been revised by the Joint Writing Committee. According to the revised version, Stage A is those at risk of heart failure without current or prior symptoms or signs of heart failure. They do not have structural or biomarker evidence of heart disease. Stage B, pre-heart failure, is also for patients without current or prior symptoms or signs of heart failure, but they have evidence of structural heart disease or abnormal cardiac function or elevated natriuretic peptides. Stage C is heart failure with current or prior symptoms and or signs of heart failure caused by a structural and or functional cardiac abnormality. Stage D is advanced heart failure with severe symptoms and or signs of heart failure at rest, recurrent hospitalizations despite guideline-directed management and therapy (GDMT), refractory or intolerant to GDMT, requiring advanced therapies such as consideration for transplant, mechanical circulatory support, or palliative care. In addition to the universal definition and revised staging of heart failure, the Joint Writing Committee has also proposed a new and revised classification of heart failure according to left ventricular ejection fraction as well. Heart failure with reduced ejection fraction, HFrEF, is defined as heart failure with left ventricular ejection fraction of 40% or less. Heart failure with mildly reduced ejection fraction, HFmrEF, is heart failure with left ventricular ejection fraction from 41% to 49%. Heart failure with preserved ejection fraction, HFpEF, is heart failure with left ventricular ejection fraction of 50% or more. Heart failure with improved ejection fraction, HFIMPEF, is heart failure with a baseline left ventricular ejection fraction of 40% or less, a 10-point or more increase from baseline left ventricular ejection fraction, and a second measurement of left ventricular ejection fraction of more than 40%. Natriuretic peptides in the definition are brain natriuretic peptide BNP and N-terminal prohormone of brain natriuretic peptide NT-proBNP. They are an integral component in the diagnosis of heart failure. In addition, the authors have a list of typical and less typical symptoms of heart failure. Signs of heart failure have been given as those which are more specific and less specific. Free access to full text of the article is available at Journal of Cardiac Failure website. Though it is a big list, it is worth reading for every clinician and other persons involved in the care of heart failure patients. Heart failure with improved ejection fraction is heart failure with a baseline left ventricular ejection fraction of 40% or less, a 10-point or more increase from baseline left ventricular ejection fraction, and a second measurement of left ventricular ejection fraction of more than 40%. This was known as heart failure with recovered ejection fraction earlier. The terminology has been revised as per the Universal Definition and Classification of Heart Failure published in 2021. The Universal Definition and Classification have been published by a joint writing committee of Heart Failure Society of America, Heart Failure Association of the European Society of Cardiology, and Japanese Heart Failure Society. The definition has been endorsed by major heart failure societies worldwide. In the initial report mentioned as above, of a total of 358 patients in their retrospective analysis, 121 had recovered left ventricular ejection fraction. They had the mildest reported heart failure symptoms and fewest previous heart failure hospitalizations. The Penn heart failure study was a prospective cohort of 1,821 chronic heart failure patients recruited from tertiary heart failure clinics. They defined heart failure with recovered ejection fraction if ejection fraction on enrollment was 50% or more, but prior ejection fraction was less than 40%. Many of them had abnormal biomarker profile at baseline, including 44% with detectable troponin I. But median levels of brain natriuretic peptide, troponin I, and creatinine were greater in heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. The authors concluded that the group of heart failure with recovered ejection fraction had better event-free survival than the other two groups. Normalization of left ventricular systolic function was associated with a significant improvement in health-related quality of life in another brief report. They noted that for each 10% increase in left ventricular ejection fraction, the Kansas City Cardiomyopathy Questionnaire score improved by a mean of 4.8 points. A word of caution is needed in the discussion on heart failure with improved ejection fraction. Recovered ejection fraction need not mean that the heart has recovered fully. TRED-HF study showed that many patients deemed to have recovered from dilated cardiomyopathy will relapse following treatment withdrawal. The study had enrolled 51 patients in 2016 to 2017. 25 were randomly assigned to the treatment withdrawal group and 26 to continue treatment. 44% of those assigned to treatment withdrawal had relapse compared to none in the group assigned to continue treatment over the first 6 months. After 6 months, 25 of the 26 patients initially assigned to continue treatment attempted its withdrawal. During the following 6 months, 9 of them had a relapse. No deaths were reported in either groups. Based on these observations, JACC Scientific Expert Panel has recommended that guideline-directed medical therapy should not be stopped in those with recovered ejection fraction. The panel report also suggested that those already on an implantable cardioverter defibrillator (ICD) will benefit from the continued usage, as a meta-analysis had shown a 3.3% per year rate of appropriate ICD therapy among those with left ventricular ejection fraction of 45% or more. They also mentioned that as a rule, cardiac resynchronization therapy should be maintained because electrical dyssynchrony and forward left ventricular remodeling are known to recur with loss of resynchronization. Here are the first set of journal references. Second set of references are here. Final set of references. Reduced exercise tolerance is an important symptom of heart failure regardless of the left ventricular ejection fraction, meaning that it is present in all forms of heart failure. Hence the role of objective assessment of functional capacity by cardiopulmonary exercise testing, CPET. Peak oxygen consumption measured by CPET is predictive of prognosis in heart failure with preserved ejection fraction, HFpEF, heart failure with mid-range ejection fraction, HFmrEF, and heart failure with reduced ejection fraction, HFrEF. CPET is routinely used in prognostic evaluation in patients with HFrEF. Peak oxygen consumption VO2 and the minute ventilation by carbon dioxide production VE by VCO2 slope are powerful prognostic predictors in HFrEF. CPET is probably an underutilized test for risk stratification in HFpEF. CPET is usually done using an upright cycle ergometer with the subject breathing room air, though it may be rarely done using a treadmill. Ventilatory expired gas analysis system is used to measure minute ventilation VE, oxygen consumption VO2, and carbon dioxide production VCO2. Fast responding oxygen and carbon dioxide sensors in the system acquire this information on a breath-to-breath basis, analyzes and displays it continuously. Highest 10-second average VO2 during the last stage of the symptom-limited exercise test is taken as the peak VO2. VE by VCO2 slope is taken from rest values to the gas exchange at peak exercise. Discussion on left ventricular remodeling. Left ventricular remodeling occurs in response to left ventricular stress and injury. It is progressive and occurs after large myocardial infarctions and dilated cardiomyopathy. Left ventricular volume increases and the normal elliptical shape becomes globular. Left ventricular remodeling is associated with changes at microscopic level which include myocyte hypertrophy, apoptosis, and increased interstitial collagen deposition. Left ventricular remodeling is a central pathophysiological mechanism in advancing heart failure. Reversal of remodeling with treatment is an important goal in the management of heart failure. Treatment modality could be either drugs or devices depending on the clinical scenario. In post-myocardial infarction remodeling, two processes are infarct expansion and enlargement of the rest of the left ventricle. Infarct expansion occurs in the process of fibrotic repair of the necrotic area with scar formation and thinning of the infarct zone. Increase in left ventricular volume is initially beneficial as the force of contraction increases according to Starling's law. Volume overload hypertrophy occurs in the non-infarcted segments. But as the left ventricle assumes a spherical shape later, it leads to decline in performance. In idiopathic dilated cardiomyopathy, there is elevated wall stress and left ventricle assumes a more spherical shape. A study comparing survivors and non-survivors showed that survivors had a small left ventricular end diastolic short axis dimension but a similar long axis length. Left ventricular cavity was more spherical in those with poorer survival. The study did not find any difference in systolic cavity dimension, wall thickness, cavity volume, or fractional shortening between survivors and non-survivors. Pathologic left ventricular remodeling is associated with neuroendocrine activation, which are triggered by the increased left ventricular wall stress and hemodynamic derangement. Both angiotensin converting enzyme inhibitors and angiotensin receptor blockers are useful in prevention of adverse left ventricular remodeling. Reverse remodeling has been documented by radionuclide ventriculograms. This translates into reduced disease progression and mortality rates in patients with heart failure. Similarly, treatment with beta blockers can also prevent left ventricular remodeling after acute myocardial infarction. Carvedilol treatment started early after acute myocardial infarction attenuated left ventricular remodeling in patients with persistent left ventricular systolic dysfunction before discharge. Addition of carvedilol to standard therapy including angiotensin converting enzyme inhibitor was found to reduce clinical progression in patients who were only mildly symptomatic with well-compensated heart failure. This was a study by the US Carvedilol Heart Failure Study Group. Angiotensin receptor neprilysin inhibitor sacubitril valsartan has been shown to be superior to enalapril in reducing cardiovascular mortality in the Paradigm HF study. A meta-analysis of 20 studies enrolling 10,175 patients concluded that ARNI was superior to angiotensin converting enzyme inhibitors and angiotensin receptor blockers in improving left ventricular remodeling in heart failure patients with reduced ejection fraction. Cardiac resynchronization therapy is another treatment modality which has been shown to improve left ventricular remodeling. An analysis of companion study showed that those with larger baseline left ventricular end diastolic dimension index had a reduction in all-cause mortality and heart failure hospitalization with CRT. Here are the first set of references on left ventricular remodeling. Second set of references on left ventricular remodeling are here. These are the third set of references. Discussion on left ventricular reverse remodeling. Left ventricular remodeling, which starts initially as a beneficial process, becomes detrimental later on, leading to progressive worsening of left ventricular dilatation and dysfunction. Reverse left ventricular remodeling is a beneficial process which occurs after optimal medical therapy or cardiac resynchronization therapy in heart failure. Similar reverse remodeling has been described after valve replacement and repair procedures. Yu and colleagues studied reverse left ventricular remodeling in 141 patients with advanced heart failure who received cardiac resynchronization therapy and was followed up for a mean period of 695 days. There were 22 deaths in the study period, mostly due to heart failure and sudden cardiac death. They checked the relation between the reduction of left ventricular and systolic volume at 3 to 6 months and long-term clinical outcome. They found that a reduction of left ventricular and systolic volume of 9.5% or more had a sensitivity of 70% and specificity of 70% for predicting all-cause mortality. Corresponding figures for cardiovascular mortality were 87% and 69% respectively. This cutoff value identified 61.7% as responders to reverse remodeling. All-cause mortality was significantly lower in responders, 6.9% versus 30.6%. Cardiovascular mortality was 2.3% in responders compared to 24.1% in non-responders. Heart failure events were 11.5% in responders and 33.3% in non-responders. In this study, change in left ventricular and systolic volume was the single most important predictor of all-cause mortality and cardiovascular mortality. Clinical parameters could not predict outcome events in this study. Similar beneficial effect on LV remodeling was demonstrated long back in the trials with angiotensin converting enzyme inhibitors. Studies of left ventricular dysfunction trial showed that in patients with heart failure and reduced LV ejection fraction, chronic treatment with angiotensin converting enzyme inhibitor enalapril prevented progressive LV dilatation, systolic dysfunction and increase in end-systolic volume. Mean end-systolic volume decreased from 106 to 93 ml per meter squared in the study group, while it increased from 103 to 116 ml per meter squared in the control group. Survival and ventricular enlargement trial with captopril showed that LV end-diastolic and end-systolic areas at 1 year were larger in placebo group than in captopril group. They noted that LV enlargement and dysfunction after myocardial infarction were associated with the development of adverse cardiac events. Preventing ventricular enlargement with captopril was associated with a reduction in adverse events. LV reverse remodeling after CRT with more than 20% reduction in LV and systolic volume is considered to be much larger than that observed in medical therapy for heart failure. Generally, about 1/3 of patients do not respond well to CRT. Lack of clinical response and absence of LV reverse remodeling has been included in the definition of non-responders to CRT. A discord between those with and without left bundle branch block has been reported in a sub-study of MADIT CRT. Authors compared patients with CRT alone and those with CRT and defibrillator who had echocardiograms available at 1 year. Patients in the sub-study were stratified by the presence or absence of LBBB. In those with LBBB on CRT-D, a median reduction in LV and systolic volume of more than 35% significantly reduced the risk of long-term mortality and heart failure events compared to patients with ICDs alone. In patients without LBBB, there was no survival benefit despite a reduction of LV and systolic volume more than the median 27.6%. Those with LBBB and least reverse remodeling had more than threefold risk for death compared with those with ICDs only. Authors concluded that despite LV reverse remodeling with CRT-D, there was no survival benefit and potential harm in patients without LBBB. Left ventricular reverse remodeling in patients with idiopathic dilated cardiomyopathy on medical therapy has been reported in a study of 361 patients. They defined LV reverse remodeling as increase of LV ejection fraction more than or equal to 10 units or a LV ejection fraction more than or equal to 50% and a decrease in indexed LV end-diastolic diameter of more than or equal to 10% or indexed LV end-diastolic diameter of more than or equal to 33 mm per meter squared. LV reverse remodeling was noted in 37% of the patients surviving 2 years. LV reverse remodeling on tailored medical therapy at midterm follow-up predicted a lower rate of major cardiovascular events on long-term follow-up. Mean follow-up period was 110 months for the surviving patients after the midterm follow-up at 24 months. LV reverse remodeling has been documented in patients with severe aortic regurgitation undergoing aortic valve replacement. They defined reverse remodeling of LV as more than or equal to 10% reduction in measures of LV volumes. They noted that LV reverse remodeling as assessed by the Tichols method was underestimated by a mean of 31 ml per meter squared compared to Simpson method. Echocardiographic parameters indicating reverse LV remodeling at 1 year after aortic valve replacement are important predictors of long-term outcomes after aortic valve replacement. LV reverse remodeling was associated with significantly reduced event rate at 2 years after mid-tract procedure for mitral regurgitation. In that study, LV reverse remodeling was defined as more than or equal to 10% of the LV and diastolic diameter after 12 months. This was noted in 49% of the patients. The study included both degenerative mitral regurgitation and functional mitral regurgitation. In degenerative mitral regurgitation, presence of recurrent or residual severe mitral regurgitation at 12 months inversely predicted LV reverse remodeling. In functional MR, residual severe tricuspid regurgitation inversely predicted LV reverse remodeling. First set of journal references. Second set of journal references. Third set of journal references. Final set of references. Thank you for watching this video. Please subscribe, like, share and post your valuable comment below this video. Kindly press the bell icon after that for getting all updates.